right. Next is comparison of transcarotid artery revascularization and transfemoral carotid artery stenting outcomes among symptomatic and asymptomatic patients based on lesion calcification by Dr. Zhu.
Hello, my name is Jerry Zhu. I'm a second-year medical student at the Icahn School of Medicine at Mount Sinai. It's my great honor to present to you our findings, comparison of transcarotid artery revascularization and transfemoral carotid artery stenting based on anatomic factors. I have no financial disclosures relevant to this presentation. I'd like to begin with a review. Carotid artery stenosis is an area of the carotid artery most commonly due to atherosclerosis and implicated in 20 to 40% of all strokes in the United States. The severity of carotid artery stenosis can be divided into moderate and severe by the percentage of stenosis and circumferential calcification. Operative modalities for revascularization include carotid endarterectomy, or CEA, transfemoral carotid artery stenosis, or TFCAS, and transcarotid artery revascularization, or TCAR. Carotid lesion characteristics remain important for technical success in carotid revascularization. Severe lesion calcification and aortic arch type 3 are considered high risk for carotid artery stenting. However, current research on the impact of calcification and other anatomic factors which affect carotid artery stenting remain limited. In this 2017 Journal of Vascular Surgery article, Abu Ram and colleagues compared stroke rates following carotid artery stenting and found higher rates of stroke associated with heavy calcification. Therefore, we aim to better characterize the impact of anatomic factors on revascularization success. Our research questions were twofold. One, does the degree of circumferential calcification affect in-hospital adverse outcomes after TCAR versus TFCAS based on symptom status? And two, do complex aortic arch types increase the risk of adverse in-hospital events following carotid artery stenting? Data was collected from patients in the Society for Vascular Surgery Vascular Quality Initiative database undergoing TCAR or TFCAS and had a non-missing grading on carotid artery calcification or aortic arch type. This totaled 9,868 entries. This was further broken down by revascularization approach. TFCAS represented 57.2% of entries, while TCAR represented 42.8% of entries. We further stratified this based on the symptom status of the patient and the degree of calcification or aortic arch type. Primary outcomes included in-hospital stroke, death, and a composite outcome of stroke death. Secondary outcomes included post-op complications and the composite outcomes of stroke death MI, as well as TIA stroke. The different symptom status cohorts were fairly similar. However, there were differences between patients based on the revascularization approach of TCAR or TFCAS. TCAR patients were generally older, of white racial background, and had more comorbidities such as coronary artery disease, congestive heart failure, hypertension, and were more likely to have previously smoked compared to TFCAS patients. We begin our discussion with circumferential calcification among symptomatic patients. Comparing the revascularization approach of TCAR versus TFCAS, there is no significant difference in rates of stroke or stroke TIA based on the treatment type. However, there was an upward trend of increased risk of these events of stroke or stroke TIA only after TFCAS. Incidence of these events after TCAR remained similar. This may suggest that TFCAS could be associated with increased risk of stroke and more calcified lesions. TCAR patients also had lower rates of death, and stroke death MI as compared to TFCAS patients with moderate to severe calcification, and we define this as greater than 50% circumferential calcification. This may indicate that TCAR is particularly protective on patients with calcified lesions. Moreover, if we focus on death, TCAR had significantly lower risk of death at all degrees of calcification compared to TFCAS, suggesting that TCAR is protective against death despite the presence of lesion calcification. And I'd like to just point out that rates of post-op complications were consistently higher after TFCAS among symptomatic patients. Now moving to asymptomatic patients, similar to symptomatic patients, asymptomatic patients had significantly lower rates of death at all levels of calcification after TCAR. Rates of adverse events following TCAR appeared to be lower than TFCAS for stroke and composite outcomes, including stroke. Now looking at the aortic arch type among both symptomatic and asymptomatic patients, The rate of major adverse events were similar between TCAR and TFCAS. There was an increased risk of stroke among aortic arch types 2 and 3 as compared to aortic arch type 1, and this was seen in both symptomatic and asymptomatic patients. However, comparing aortic arch types globally, there was not a single aortic arch type which enhanced or decreased the benefit of TCAR over TFCAS. So in summary, our calcification analysis revealed that TFCAS trended with increased risk of stroke with increased calcification only among symptomatic patients. However, risk of stroke among symptomatic patients stayed the same after TCAR. Our second finding was that TCAR is associated with significantly reduced rates of death and composite outcomes with moderate to severe calcification among symptomatic patients. And regardless of the symptomatic status, TCAR had lower risk of death at all degrees of calcification compared to TFCAS, and this may indicate that TCAR is protective against death despite anatomic differences or symptom status. And our findings are likely due to the enhanced neuroprotection offered by direct carotid access and flow reversal with TCAR. And in regards to aortic arch type, our findings were that 1, TCAR consistently trended with decreased risk of adverse events compared to TFCAS, and complex aortic arch types 2 and 3 did not enhance nor decrease the TCAR mortality benefit over TFCAS. Our study has several limitations. 1, selection bias inherent to the VQI due to the self-reported nature of the data. 2, causal conclusions cannot be made because this is an observational study design. 3, different time periods were analyzed for TCAR since it is a newer procedure. And 4th, operator expertise may underestimate the benefit of TCAR as it is a newer procedure. So in conclusion, TCAR is protective against death despite anatomic differences and may be particularly beneficial over TFCAS in patients with calcified lesions, and aortic arch type may not be a major contributing factor in outcomes following carotid artery stenting. Thank you very much.
All right, the paper is open for discussion.
Hey there, great paper. Joseph Tingen, fellow, Prisma, Greenville, South Carolina. Really nice paper and good data. I was wondering if you had the numbers on how many of the transfemoral used embolic protection device, and if that any used MoMA or reversal of flow transfemoral. Thanks.
Thank you for your question. So in terms of a transfemoral carotid artery stenting, we based the approach as our kind of criteria for including it. So I don't have the number off the top of my head. I can definitely get back to you. But the major difference between TCAR and the TFCAS patients with the data we used from the VQI was with a flow reversal and a time point. There is some data prior to 2017, which isn't consistent in VQI in terms of if it actually used a flow reversal.
Great. Vic Kashup from Cleveland. First of all, you're a medical student, Jerry?
That's correct.
Yeah, well, congratulations. That was beautifully presented. Your data corroborates what we've also seen, that TCAR is probably preferential to TFCAS. My question for you is, when there's severe calcification, we often have different approaches. We can do either pre-dilatation only, pre- and post-dilatation, or just post-dilatation after stent placement. Do you have any correlation data of what the angioplasty technique was done with increasing calcification burden? Thank you.
Thank you. I actually don't have that kind of expertise, but I can definitely get back to you once I consult with my attending.
Maybe another quick question for Dr. Ferries there. Just as you set up the hypothesis and the comparison, if we already generally accept that circumferentially calcified lesions are probably higher risk for stenting, and if we're suggesting that TCAR might be a better approach for that, would a comparison with CEA on calcified lesions be the more or the better comparator?
Yeah, I think that's an excellent suggestion. These are our clinical database of EQI data, so it's good to give, I think, an impression of where we're going and what the data may be reflective of, but I think additional studies are going to be needed to bear out these initial observations. Also, I thought the comments and questions were excellent. We'll try to get you the information on how many of the transfemoral patients had proximal protection and how much pre and post dilatation was carried out. In our own sort of anecdotal experience, we've seen with more heavily, we have started using TCAR for more heavily calcified lesions. We have not done so for transfemoral. You do seem to get a little bit of recoil. And so I've used post dilatation with TCAR more frequently than with transfemoral. And again, that may be related to recoil from those calcified lesions. But yeah, I think that would be great to compare TCAR to carotid endarterectomy for heavily calcified lesions.
Final question.
Last question, more so for everybody in here, is regarding calcified lesions. I've actually seen people and occasionally using the lithotripsy balloon with TCAR. Are people doing that all over, or is that just kind of regional and occasional? So I've seen that. I have partners who've done it, and I'm just wondering how aggressive people are getting with calcified lesions and using the lithotripsy balloon, the shockwave.
So maybe by raise of hands, how many people have done more than 5 IVL of the carotid lesion prior to TCAR or TFCAS? More than 1.
1.
There you go. I think, Jerry, congratulations. It looks like you already have your project for next year. So
Thank you
thanks.
very much.
Okay.